This is really exciting. No more zombie guidelines, no more guidelines that are immediately out of date as soon as they hit the publication. Our guidelines are alive and they are staying alive through magic. So if clinicians want to go to www.magicapp.org, you can find our Canadian treatment recommendations on the Magic app, and you can access that to see the current treatment recommendations, all of the background data that supports the treatment recommendations, as well as the thought process that went behind the treatment recommendations.
That's Dr. Sherry Rohekar. She's an associate professor in the Division of Rheumatology at Western University. She has a master's in clinical epidemiology and focuses her research on clinical outcomes in spondyloarthritis. She is currently on the executive committee of the Spondyloarthritis Research Consortium of Canada. Her latest project has been updating Canadian Rheumatology Association treatment recommendations for spondyloarthritis in Canada. We're thrilled to have her as our guest to talk about those updated guidelines here on Around the Room. Welcome, listeners. I'm Daniel Ennis, and a warm welcome back to my fellow host, Dr. Janet Pope. Janet, how are you doing?
Good. How are you, Daniel?
I'm actually quite excited about this conversation because I would consider spondyloarthritis to be kind of one of my many weak spots, and so I'm hoping that Sherry will help me get a little bit better at that. But before we bring her into the conversation, there's some good news. So the CRA annual scientific meeting is taking place from February 26th to March 1st in Calgary, and Around the Room will be there. So we'll be recording some interviews and some episodes at the ASM. So if we see you, please stop and say hello, and we always love hearing from listeners. So we're really looking forward to that. And anyone who has not signed up to go to the CRA in Calgary definitely should, because I think it's going to be a great deal of fun. So enough fun stuff, time to get down to business. Sherry, thank you so much for coming on the podcast, and welcome.
Oh, thank you so much for having me. It's a thrill to be here.
I'm thrilled. So maybe we can start off broad. I'm hoping that you can just introduce the recommendations you've written and explain who and what they're meant to address in broad terms.
Well, the last update of the CRA SPARCC treatment recommendations were written in 2014 and were published in 2015. And obviously, since then, there have been significant changes in the available therapeutics, both for axial and peripheral spondyloarthritis. And while other groups like the ACR and EULAR have published treatment recommendations, there still really is a need for treatment recommendations that reflect Canadian rheumatology practices. So in our last treatment recommendations, we had addressed predominantly peripheral spondyloarthritis, so that's largely PSA, psoriatic arthritis, predominantly axial spondyloarthritis, as well as juvenile spondyloarthritis, or what's better known as enthesitis-related arthritis. For the purposes of efficiency, we actually broke this down into 3 different groups, and our current recommendations that were just published really reflect predominantly axial spondyloarthritis. And we used a new methodology for this. So we used a grade development methodology, which is a big change from the 2014 update. And for those of you who are wondering what a development is, that's kind of a new word in the dictionary, and I will get to that in a second. The grade methodology is the same methodology that's used for a lot of guidelines. So that's been out there for a while. So that's the grading of recommendations, assessment, development, and evaluation, which is this really high quality system for appraising evidence quality and then developing a strength of recommendations. And it's really what's the gold standard for most treatment recommendations these days. And it's allowing us to use a transparent, structured process to really assess publications, to look at study limitations, imprecision, inconsistency, indirectness, and publication bias. But what exactly is adultment? So adultment is kind of a mishmash of 2 words, adopt and develop. So that's when you take existing recommendations from other groups and you adopt and develop them to apply to your patient population or your treatment recommendation group, in this case, a Canadian patient population. So we adopted and developed the ACR treatment recommendations as well as the Australian treatment recommendations for treatment of axial spondyloarthritis. And we took those treatment recommendations and adopted them so that they applied to a Canadian population. And what this really does is it saves us a lot of time and a lot of effort because the data is the data. The papers that give us the information about how to treat axial spondyloarthritis and the data that is in those papers is the same. However, what may come out of those papers and how you interpret them for your patient population may be different depending on where you are and what treatment population that you have. So that's what development means. It means that you can use other guidelines and build on those and develop them so that they really apply to your patient population.
So it could kind of save you time, and it could also be the Canadian context of access of one drug and another.
Absolutely. And certainly there are things that, for example, in the ACR guidelines, would not apply to a Canadian population and would need to be adjusted. So that's what adultment means.
Didn't know what that was. That's actually quite interesting. And I wonder if that dovetails at all with one subtlety here, which is you point out in the guidelines that it's a living guideline or living recommendations where this is something that is it sort of recognizes that it's an iterative process by its very nature, and that publishing, last time in 2014, 2015, well, things happen quite a bit faster than how quickly you can do a full revamp, a full new meta-analysis, a full new, Cochrane review of all of the literature. Can you kind of just explain what like a living guideline looks like, or how we're going to experience that as physicians?
Yeah, so I think this is really exciting. So this is another, I think, way of the future for guidelines is that no more zombie guidelines, no more guidelines that are immediately out of date as soon as they hit the publication. Um, so our guidelines are alive and will be alive, and they are staying alive through magic. And I don't mean that sarcastically. I actually mean that because they are staying alive through something called the Magic app. So if clinicians want to go to www.magicapp.org, spelled exactly like you would imagine it, you can find our Canadian treatment recommendations on the Magic app. And you can access that to see the current treatment recommendations. And you can also see all of the background data that supports the treatment recommendations, as well as the thought process that went behind the treatment recommendations in complete detail behind each and every recommendation. And as new data emerges, we can go onto the Magic app and we can change or update each recommendation, or we can add new recommendations. So if a new molecule, for example, comes to market, rather than redoing the whole guidelines from step one and having to redo the whole literature search, we can now add a new PICO question, add a new treatment recommendation, and then send out a blurb to the Canadian population, to, for example, the CRA, saying that there's been an update, a major update to the Canadian treatment recommendations, and to check out the Magic app to see what the new recommendations are. So it makes things dynamic rather than static.
I do have a question about that because the RA guidelines have been dolloped somewhat, and they're coming out piece by piece. But isn't it reliant on somebody actually updating so that they are alive in that when someone updates and puts it in an app or has a consensus that it goes in? But if I don't update and don't look, AI isn't doing it, right? No one's doing it for you.
No, no one's doing it for us, unfortunately. It would be nice if there was some sort of bot that was checking things over and doing it for us. But that does mean that we do have to stay vigilant, and we do have our working group that will have to continue to have our onerous Zoom meetings. And when new issues come up, we will have to continue to meet and then assign those topics to people to go over and
And
load
get
up.
consensus too.
Absolutely,
Yeah.
absolutely.
And Janet, like you've been obviously involved in the writing of a lot of different guidelines, and I wonder how that strikes you, because once you write a guideline, then it just, as Sherry had said, they kind of immediately, or a new big paper comes out, that the next scientific
Right.
meeting,
It can
and
nullify.
suddenly, yeah. Do you find this to be kind of a major advancement from your perspective?
I think it's an advancement, and the CRA has certainly invested time and expertise in the app, in having consultants. And I think as well, because we don't want to do the thousands of hours of work that Sherry just finished every single time the next class of drugs, or even within a class, a subclass, or looking at enthesitis in a different way or whatever. So every time something new comes out, I think this is a huge advantage to say guideline for A has changed, as a for instance, to this thing. And then in more or less real time, we can all learn more and do more, or do better. So I think
Hmm.
the CRA is taking a leadership role in this. And really, Australia is partnering in a lot of living guidelines, and now even ACR is.
So the ACR will be doing their spa update, and they will be living as well, as far as I know. So I think that's the way of the future.
Excellent. Well, let's then maybe get into some of the recommendations. And you've kind of divided it into various component parts. But one of the ways that it's divided into is kind of who are we talking about? So is it active axial spondyloarthropathy? Is it stable, or is it for both active and stable? And then other areas as well. But if we can maybe start with the active axial spondyloarthropathy group, we won't have time to go through all of the recommendations. So maybe I picked out a couple of areas that I was hoping we could talk about. And so one recommendation, and I'm not going through the precise kind of strong, weak recommendation, but there's some that I just wanted to spend a bit of time on. So there's a recommendation for continuous use of NSAIDs preferred over as needed use of NSAIDs for patients with active axial spondyloarthropathy. And I think that that's actually kind of an interesting recommendation, because I've seen variable practices where some people will give a 2-week course. Some people will say, use it as needed or when it's bad enough, because essentially these NSAIDs are just for symptom control. And I'm wondering if you can kind of give a little bit of context to this recommendation here.
Right. So that was a conditional recommendation for, and you have to keep in mind that this is for patients with active disease. So there is some evidence that for active disease, there is some benefit for continuous use of NSAID. This is based on some studies that are perhaps not the strongest studies, in the sense that the RCTs are a little bit all over the place. But there are some studies showing that particularly the COX-2 inhibitors, when used on a continuous basis versus a PRN basis, may show some improvements in patient outcomes when used continuously versus PRN. So that did get a conditional recommendation for, particularly in active disease. When patients are on or sort of get into a more stable category, that drops off to a as needed basis.
And Daniel, just as I recall, and Sherry will correct me if I'm recalling incorrectly, there was an RCT, a large one, of Celebrex PRN, an active axial SPA versus regular. So regular was 400 milligrams a day, and PRN was do what you feel like doing according to symptoms. and there were less syndesmophytes forming, as I recall. But the difference was Celebrex on average, something like 342 milligrams a day versus the PRN 300 milligrams a day. So I did wonder if it was true what they found, but if it was spurious because it's so close on dosing. But other studies have shown with active SPA, around the clock dosing of other NSAIDs as well might give less radiographic damage over time. Have I kind of got that right,
Yeah,
Sherry?
yeah, and it seems to be more with the COX-2 inhibitors than, with the non-COX-2 inhibitors, which is weird, and again, the cumulative dose of NSAIDs, seems to be the same in both groups, but there's something about the regularity of the dose that seems
Right.
to
And it could be area under the curve of suppressing that CRP down or something, right?
Mhm.
Because the half-life on celecoxib of BID dosing wouldn't be the same if I take it 3 days in a row regularly and then not for 4 days,
Right.
right? I'd be kinda washed out. Is that what you do, Daniel?
In terms of how I usually use it continuously until suppression of symptoms, and then as needed thereafter, it was kind of my general practice. I'm curious, just following up on an item, you've pointed to that evidence being present for COX-2 inhibitors, but the guidelines actually kind of specifically say that it gives no preference to any specific NSAID, or it doesn't
Right.
rank them. And I'm wondering, maybe outside of the guidelines, do you have specific ones that you use, or is there a reason why COX-2 inhibitors were not elevated based on the data that you're using there? I wonder if you can kind of fill that in.
I think there's not enough data to really say that COX-2 inhibitors are superior to non-COX-2 inhibitors, and each patient is so individual in how they respond.
Hmm.
I do have to admit that I probably go to celecoxib first because of that one study that Janet mentioned, and because of the gastroprotection, and I don't like having my GI colleagues getting mad at me
Right.
when someone gets an ulcer. But
Sure.
um, but I think, in general, I'd choose whichever NSAID works for the patient, and, I don't really shy away from anything as long as it seems to be working for the patient.
Janet, you have a favorite?
Well, back in the days gone by, indomethacin was supposed to be very strong on inflammation. I don't think we like using it chronically because of hypertension, the gastric lack of protection, creatinine going up, etc.
Hmm.
So I do as well. I think because Sherry sits very close to me in clinic, she has cross-contaminated. So I use a lot of celecoxib, but I use naproxen, meloxicam, diclofenac, rarely indomethacin. I don't love indomethacin chronically for those reasons, but
Hmm.
so no, not really. I think as Sherry said, whatever seems to work for the patient, that seems to be the one that they'll want to continue.
Very fair. And then, kind of something that I think is not addressed in the guidelines, and I wonder if you have any insights into it, is really kind of the age cutoff for NSAID use. There isn't one, but I think we kind of feel it in our gut
Mm.
as a patient gets on in age, and we're
Or a Derek
using.
Watt.
Yeah, exactly. Yeah. Is this the right long-term strategy as someone's getting older? If you hit 65 and you had some coronary artery disease, would you want to just go on to that TNF inhibitor? Or would you want to keep on the NSAIDs? And how do we kind of make a decision there?
That's a great point. Some of this is in the fine print and the Magic app if you go through all the little tabs, in the evidence, but there is actually some really good evidence that being on an NSAID, and reducing inflammation actually counteracts the potentially, cardiotoxic, effects of the NSAID itself. So, in the past, Nisha Haroon has, written a paper about how the chronic NSAID use does not increase cardiovascular risk in patients with ankylosing spondylitis. And just at the last ACR, there was a poster presentation showing no increase in hypertension with increased with chronic NSAID use in patients with ankylosing spondylitis. Unfortunately, I forget the name of the author on that one. So it seems like the the reduction in inflammation and the reduction in cardiovascular risk by decreasing the inflammation with the chronic use of NSAIDs seems to be more important than whatever potential cardiovascular risk you can get by the chronic use of NSAIDs.
Right. And when Nigel did that, I think it was the Ontario data, so a big database. And there's a large Korean, basically like a billing administrative database that showed the same thing, whereas age and sex matched patients without ANG-SPON had increased cardiovascular events if they were on chronic NSAID, sort of a dose response. Whereas in ankylosing spondylitis, as you said, Sherry, they didn't find that. It actually looked protective. So it's almost like a paradox, but I guess if you can get that CRP down, control inflammation, and I always think pain probably raises your blood pressure as well. Stuff we don't talk
Yeah.
about too much, but if people are in chronic pain, I don't think they're happy campers either.
Yeah, absolutely. I also like, I mean, this isn't, no one's here to listen to my opinion, but I also wonder about kind of people's mobility and their ability to exercise and stay activated and even get up and walk, which we know has kind of significant
right.
cardioprotective benefit compared to being a couch potato, like I was over the weekend. Okay, so that's just kind of the NSAIDs, and then moving on to the biologics, I think there are some really interesting pieces in here. So a number of new biologic options have kind of come up since the 2014 guidelines, and specifically these new recommendations include comments on the IL-17 and JAK inhibitors, and kind of on balance largely hold no major preference for any particular biologic or JAK as first line, though there is a caveat that currently JAK inhibitors are only available for the treatment of axial SpA after the failure of another biologic. So in terms of kind of order of operations, these guidelines seem to kind of reflect starting, and do correct me if I'm kind of misreading this, largely speaking, starting with TNF, moving on to IL-17, and then JAK inhibitor, sort of in that order. It doesn't say that explicitly, but that's sort of the flavor I get. I'm wondering if you can kind of direct me to the actual truth.
So I would say the actual truth is a little bit closer to TNF inhibition or IL-17 inhibition, both good options for first line, with no preference for either. With JAK inhibition falling slightly below those two simply because of the potential cardiovascular and MACE risk, um, which although has not been demonstrated in axial spondyloarthritis. In fact, there is no evidence of that cardiovascular risk and MACE risk in any of the axial SpA studies. Uh, that has not been shown. That's only been shown in observational trials, not in randomized controlled trials. So the randomized controlled trials in using the grade system, because of that, the way that the grade system works, that means that the JAKs did get knocked down a little bit because of that evidence from the rheumatoid arthritis oral surveillance data. But we didn't differentiate between TNF and IL-17 as first line. I think either one is a good choice. There was a lot of debate about whether or not JAK inhibition should be at the same first choice level as well. I think a lot of clinicians specializing in AxSpA would agree that there is no real clear data showing that there is an increased cardiovascular risk or MACE risk in axial spondyloarthritis patients, and lots of observational data that shows that there is not either. It's kind of a moot point in Canada because we do have to fail one of the other ones first. The way the recommendations work, you have to take the randomized control data first, and the observational data gets put down a lot in comparison to that. So the JAKs did come out a little bit behind.
So along that note, when we're thinking of axial SpA, we'll say, so mostly axial, not peripheral, they don't have psoriasis. Would the clinicians read these guidelines and take into account, okay, they have other things, they have IBD, or they have uveitis, or a family history of MS, things like that? Is that kind of how we're supposed to use our brain when we're looking at the magic gap and sort of stratify according to risk?
But I certainly hope so. But even if you don't want to use your brain that much, there are specific recommendations for that. There's a comorbidity section, and in the guidelines themselves, we do have recommendations for which modality to use if there are specific comorbidities that are associated.
One other item in this group is about the kind of co-treatment with methotrexate. And so there's a conditional recommendation against that. And there's an explanation that essentially like the value of low-dose methotrexate in combination with biologics in rheumatoid arthritis is kind of well documented. But that benefit is not clearly demonstrated in biologic use in axial SPA. That is something that I find kind of helpful in terms of how we use our different agents, and is it necessary to keep the methotrexate going if you're not using it for peripheral arthritis or some of the other peripheral manifestations. So I found that to be a helpful recommendation there.
Yeah, yeah.
Maybe we can go on to kind of stable axial SPA. So there was a strong recommendation against abruptly stopping a biologic agent in stable disease, but conditional recommendation to dose reduce or increase the interval of biologics in patients who have achieved stability for more than 6 months. I'm wondering if there's a regimen that is actually suggested for how we should be doing that, or is that a very individual basis, kind of patient/physician directed?
There was a real emphasis on joint decision making with the physician and the patient in this, and also using caution if there were certain barriers in place, such as the physician and the patient being geographically dispersed, not being
Mm-hmm.
able to reach each other in case of flare, etc. So there's for each recommendation, one of the things that I think is really unique about the treatment recommendations is that we did have equity considerations. So we did want to make sure that these were taken into consideration, that we didn't want to have people try to taper their biologics and then flare and be left in a situation where they were sort of stuck. There is some evidence behind tapering biologics, and certainly it can be done in a portion of the population, but it has to be done with caution, and it has to be done with a very strictly defined uh, physician-patient discussion and shared decision making.
And I can say what kind of worries me when someone has axial SPA. If I think they're in remission, number one, remission's tough to tell. CRP normal, I'm not going to usually re-image them because it's difficult to get. It's a long wait time and not feasible to do that all the time unless for research purposes. So you say, I think you're doing well. Your BASDI looks okay, whatever that means, but it looks okay. Your CRP is okay. Do you want to sort of lower like change the interval or something? What I find is it's really tricky in psoriasis and psoriatic arthritis. It's easier because skin and or joints might manifest quite quickly, peripheral joints. And RA, again, we can see that they're getting arthralgic and then we see the synovitis coming. I find it very tricky to say, are you still in remission? Obviously, if symptom control is there, CRP is good, but because we can't look into the spine, I don't want them to get more new CILs or whatever, because that could end up in a syndesma fight again, even if I restart treatment. So I find it difficult. Daniel, do you tend to back off on treatment, or, with the individual patient decision, you kind of go through, you could stop, well, not stop. You can change the interval? Do you do that routinely, or you just don't bother?
I think when I'm still relatively early in practice, so most of the patients I'm seeing are kind of newer diagnoses and earlier on in treatment. Definitely, like when I'm starting treatment, I tell them like I don't even want to hear it. I don't even want to talk about tapering the medications. Like let's get you under control before we talk about reducing the doses. I recognize the 6 months of remission, and when I explain that to patients, like what I really want is or like low disease activity, but I really want to make sure that they're in like good, sustainable, long-term remission, that they're not also on a DMARD. And then I will discuss it with them. But I think making sure that they understand that it can be hard to recapture disease in a fraction of people, and that the expectation for most of these diseases is that we don't have a cure, which means that many people aren't able to have sustained drug-free remission. And so I think it has to just be done carefully. So I try and do it kind of judiciously. And most of my patients kind of, if they do stretch out the dose, we really do stretch it out. I have a few people who are on seemingly homeopathic doses of biologic, and then you stretch it out. They miss one dose for even 1 week longer, and they really feel classic inflammatory back pain. And that reminds me that we haven't cured this person. We've just found the right dose for their specific biology. Is that largely fair?
I agree with you, Daniel, and I also often find that people who are asking me about stretching out their doses already have the area.
Yeah,
It's like, when
totally.
did you start? Trainees think that we're deaf or something. I'll say, oh, when did you start changing your dose? And that trainees think that's not what they asked, but that's what they really meant.
Yeah, I take off my glasses and I look at them and I go, hey, it's me. When did you actually stop taking the medication?
The process, yeah.
um,
Yeah.
so you know, I do actually want to ask a few questions about MRI, but before we get there, the next group was the group of both active and stable axial spondyloarthropathy patients. There are some recommendations there. One that kind of comes up consistently throughout the recommendations is for physiotherapy and back exercise and group or individual self-management education. And I find that like the evidence seems to be compelling that these are helpful tools and they are good for patients. And I am bad at prescribing it. I don't really know. I know they should do these things, and they say, oh, well, so what kind of exercise? And I go, oh, geez. I have to think about that a little harder. Is there, are there specific Canadian-focused resources that kind of tell us exactly what this means, exactly what you did give some specifics about physio, so more active involvement physio rather than kind of passive physio. But is there something that I can give them in the office that's or direct them to in the office that's going to answer that question? Check that box.
So a really great resource is the Canadian Spondyloarthritis Association. They have an excellent website, and they actually have you can actually any rheumatologist can ask them to send booklets on ankylosing spondylitis and psoriatic arthritis that have illustrated physiotherapy exercises that the patient can do on their own. The patients can join for free. And the website and the Canadian Spondyloarthritis Association is working in partnership with rheumatologists like myself and other members of SPARCC. So they can go on the website and look up the physiotherapy exercises. You can get the booklets. The booklets are really nice. They also explain the disease. They're nice to hand out at the first visit. And you can order them for free to your office and hand them out when the patient is sort of overwhelmed with their explanation of everything. And they can even download an app and have that on their phone and do disease tracking, etc. So I highly recommend that as an option, because not everyone in our country gets good physiotherapy access, unfortunately.
I'm sure that our producer is going to edit out the little whoop I did when you said that, because that's such an important piece for people to access, especially since at least in BC, it is mostly private pay for physiotherapy. It's not covered. So we know it's good for people. We know they have expertise that I do not have. And it's consistently in recommendations, and yet I have no specific access to it. I happen to where I practice, but not everyone in BC does. So that is a nice free resource for patients. That's excellent. If we move to kind of one additional section of the guideline, we won't get through everything, but there's a section on assessment, screening, and imaging. And there's one thing that this is a perennial problem that I have with ankylosing spondylitis or axial spondyloarthropathy, which is my own lack of confidence in my history taking and physical exam skills. There's a weak recommendation against routine MRI when trying to make the diagnosis. And I guess I'd pose to you that, like, knowing as we do that examination and history and labs and x-rays, each of them is not sensitive enough to exclude the disease. Maybe I'm wrong about that, and I am misreading the literature, but how do we get around the relative sensitivity of the MRI?
So yeah, I think there was a conditional recommendation against obtaining a spinal or pelvis MRI in patients with stable axial spondyloarthritis.
Mm-hmm.
I agree with you. I guess to quote the Beatles, the more I learn, the less I know. But I do find that as time goes on, the less convinced I am that my history and physical exam is telling me the whole story in axial spondyloarthritis. So I do think that when making the diagnosis, there is an importance in obtaining good imaging, be that an MRI. I think usually it's an MRI for me. We're lucky enough in London to be able to get the MRI of the pelvis and the whole spine, but you can go for the money and just get the SI joints if that's what's available to you. Um, if the patient is stable, I don't think the guidelines state that there's no point in repeating that to ensure that there's stability.
Mm-hmm.
But if you're questioning whether there's a disease flare versus, is this all damage or degeneration, then certainly in my personal practice, I have used MRI to reassess that because it can be hard to know in patients who have both degenerative disc disease and axial SPA, or who have had damage from their axial SPA and are now doing well on a biologic but still complaining of pain. Whether their pain is now, nociceptive pain or damage pain, then I do repeat MRI not infrequently. So I think for the question of diagnosis, and especially for non-radiographic axial SPA, I think MRI is definitely needed.
Can I ask, Sherry, so for the trainees or the non-experts like myself listening, is it a T1, T2 stir of the SI joints? What would be the largest money if you can't get the whole spine?
Yeah, so it would be a T1, a T2 stir of the sacroiliac joints. Basically, you can just go to the to Walter Maximum, which is website, the Care Arthritis, Care Arthritis website, and see what he does, what protocol he uses, and ask your friendly neighborhood radiologist if they can copy that protocol and do that set of imaging. And you can actually do a whole imaging workshop on his website as well, and even send him your images to consult with. So, if you have questions about whether the imaging is being read correctly, he will actually read them for you.
Oh, wow.
Um,
That's
that
great.
is definitely a great resource.
Great resource.
I think we're kind of we're running towards the end of our time. I'm wondering if there are major questions not addressed in the guidelines that you kind of think are probably going to make their way into later iterations or as part of the living document. Are there kind of outstanding questions that are hot topics in SPA?
I think there's a few. I think there's going to be some questions arising around interleukin 17 A and F inhibition, and whether that's different than interleukin-17A inhibition on its own. I think there's going to be continued questions about JAK inhibition safety. As I said, there's some uncertainty around JAK inhibition safety for axial spondyloarthritis. It certainly seems to differ from rheumatoid arthritis, and whether we've sort of placed that in the correct spot on our flow charts. One of our goals is to continue to have a really strong focus on health equity. I do know that up and coming and soon to hopefully hit a growth spurt, so to speak, would be juvenile spondyloarthritis. And the PD Rheum group is really working hard on the JSPA recommendations, and they are almost hitting puberty. And then secondly, we have a lot to work on for peripheral spondyloarthritis, which will be mostly psoriatic arthritis. So we're hoping that we will have something coming out for that in more than 4.5 years, which is how long it took to get these ones out.
So can I ask 2 rapid fire questions? So number 1, is there a role of IL-23 inhibition in axial SPA?
It doesn't work, no.
So that's a good rapid fire. Number 2, if we have a patient with HLA-B27 associated uveitis, it's recurrent and or chronic, what would be your order of treatment if we need advanced therapies? So they've had their local glucocorticoids topical, they've had whatever the ophthalmologist is doing, intraocular, etc. When they ask for help, what would be your order?
So a monoclonal antibody TNF inhibitor, and then another monoclonal antibody TNF inhibitor until you run out of monoclonal antibody TNF.
And then,
And
because there is data on IL-17,
Yeah.
there's data on JAK.
there's some, so I would probably then just randomly choose one of the two. Yeah.
Okay, so TNF, maybe.
And then maybe there's some data, maybe IL-17AF, maybe.
Yeah.
But yeah.
Right, because there are, like in the axial SPA RCTs, certainly the sub-analyses when they kind of put the RCTs and long-term extension together, certainly IL-17 versus the placebo and then the expected rate and long-term extension is better on active treatment than a placebo with an NSAID. And certainly, again, looking at the JAKs, UPA and TOFA have both showing what looks like within the RCTs a reduction of uveitis or less severe uveitis, and then long-term extension, again, less problems happening. But people go into long-term extension usually because whatever they're using works. So then if it's working, it'll probably attenuate new or recurrent uveitis. But that's really helpful because I think as a non-expert in the area, I sometimes need to know, what do I do next? And although your desk is a couple desks down from me, not everyone has that advantage that's listening.
Well, you're a lucky woman, Janet. Dr. Sherry Rohekar, thanks so much for coming on the podcast. We really appreciate you breaking down these guidelines for us and their or recommendations, I should say, and they're an incredible contribution. So thank you very much.
Thank you for having me.
That's it for this episode of Around the Room. For questions, comments, and future episode ideas, email us at info@room.ca or tag our Twitter account with your question at CRASCRroom. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We'd like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fonwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. And share this episode link with your colleagues. It helps these interviews reach as wide an audience as possible. Until next time, with Janet Pope, I'm Daniel Ennis. Take care.